welcome to Experts Online, and it's lovely to see or hear all of you today. And I think we're going to have an exciting hour coming up ahead of us. We're going to talk about genetics, which I think is one of the really exciting things that are coming out in cochlear implants today. But firstly, let's just have a look at our participant tips so that we are all familiar what we need to do. Please name yourself so that we have your name and organization and country so we're familiar with who you are. It's really good to avoid background noise or music or anything, so can you please mute your microphone unless we ask you to present your questions, and also mute your phone so we don't hear it ringing. Best for a stable internet connection on your side is to recommend you close all other programs in your device so you have the best Wi-Fi for this meeting. And finally, we are really happy to have your comments and questions. They're very welcome. You can either put these in the chat during the session, or if you want to talk, you can raise your hand and then we will ask you after the session today. So those of you who would like to have captioning, if you go to the bottom, you can see that there's a box that says closed caption. And if you click on this, you will get captioning in English. So just so that you're familiar. Right, so we always like to have a Mentimeter question. We've got 2 of them today. Please can you enter the code or go on to the QR code? Was that enough time for people to go onto the code? Okay, so that everyone has the QR code so that we're ready to go. Okay, let's have a look at our first question then. All right, do you do standard genetic testing for etiology? You can choose all of the time, only if I'm concerned, or never. Okay, so far we've got all of the time. But I think a few more people need to say what they are doing, which would be very helpful for us in our quiz today. There's no quiz, don't worry. Everyone thinks that sometimes there's a presentation and there's a quiz afterwards. Good, so we have someone who said only if I'm concerned. Is there anyone else? Okay, it seems that those of you who have responded mostly do it all of the time, so that's really good to know. Right, Prof. Usami, I think that's a good thing to know. Right, so let's just have a look at hearing loss and the genetics behind it. And I think this is the thing. We have about 50 to 80% of prelingual hearing loss is due to a due to a genetic cause, and the other 40% are usually acquired in the prelingual group, of which we have about 20% are syndromic, and that's like Down syndromes or Usher syndrome, for example, and then 80% are about non-syndromic, and the familiar ones we would see are like JGB2. And then you can have of those non-syndromic, some of them are recessive, mostly about 80%, where dominant is about 20%, and there's a small group of others, so like the hearing loss associated with aminoglycoside exposure. All right, so this is Ilona's lesson on genetics in a nutshell. I hope I passed the quiz here. But cells are the building blocks of our body, so we are composed of about 100 trillion of them. And every single cell contains our genetic information. We inherit half of our genetics from each of our parents. In each cell, the genetic information is stored in the nucleus in a highly packed form, and that's the chromosome. And each chromosome has a single module of DNA, also known as a double helix. This contains a large number of genes. Okay, these really are the blueprints of our proteins, and which in turn build our cells and make them work for a very specific function. Each gene and its functionality is defined by the specific order of these chemical units, forming this step of the ladder that you see. And any changes into this blueprint may cause malfunction of the protein required by the cell, and this is why we might have a genetic cause. And if we look at the genetics of hearing loss, you can see that we have really delicate structures in the inner ear that are built by various types of cells. And these cells are often involved in the pathophysiology of hearing loss. So hundreds of genes have been identified that contribute to or cause hearing loss. But what's really important is that we need to go from the bench to the bedside. And that's the key thing. We have had major advances in deciphering the molecular background of hearing loss. And we have high throughput of sequencing, and the affordability of genetic testing has reduced. So it makes diagnosis of research and genetic hearing a lot more of a reality, and slowly becomes less expensive. And what's the benefit for this? We're moving from basic research to real benefit counseling and for patients, and choosing the right type of treatment for those patients. And I think that's what we're going to hear a lot about today. So it's my pleasure to introduce Prof. Usami. He's from the Department of Hearing Sciences at Shinshu University of Medicine. And he graduated from Hirosaki University in 1981 and did his residency training at the hospital there. He spent 1 year doing basic research at the Baylor College of Medicine in 1986. He became professor and chairman of the department at Shinshu of Medicine in 1999, and in 1920 he became emeritus professor. He continues his research on projects there, including genetic analysis of deafness and looking at various hearing plants and how they interact. He's a member of the Otorhinolaryngology Society of Japan, of CORLOS, of Barony Society, and of the Hearing Group. His research fields ranges from morphology of the inner ear to molecular biology and molecular genetics, as well as additional basic research, and furthermore looking at the clinical work that he does, such as audiology, otology, and cochlear implantation. He is interested in developing basic and clinical research to aid patients. I think that's the core of your heart, I think, Prof. Usami. He has published more than 300 reviewed articles and is on the editorial board of many journals. Besides that, he is an avid skier, as you can see on the picture, and a collector and researcher of butterflies. So, Prof. Usami, it's wonderful to have you here with us, and I know that you're up very late, so we really appreciate you being with us.
Okay, can you hear me?
Yep.
Yes. Okay, thank you for a nice introduction. And my topic for today is not skiing or butterflies, but genetics. So first of all, I would like to show you an example of how genetic testing is important. His hearing was found through newborn hearing screening. Is his hearing loss due to genetic cause or not? Of course, nobody can answer that without genetic testing. But the most common etiology of congenital hearing loss is genetic. This slide shows estimates of causes of deafness at birth in the US. When thinking about the cause of hearing loss, we have to keep in mind whether the etiology is genetic. But his parents do not have any hearing loss. Should we still consider it to be genetic? Yes, because 70 to 80% of hereditary hearing loss is due to recessive inheritance. Both parents have one allele with the mutation. The children obtain one allele from father and the other one from mother. Therefore, 1 out of 4, 25% children may have hearing loss. This patient had two GJB2 mutations, which were inherited from the parents. He received bilateral cochlear implant at the age of 10 months and at 1 year and 4 months. What is GJB2? What role does this gene play in the inner ear? This slide shows genetic background of the CI patient. GJB2 is known to be the most prevalent gene responsible for congenital hearing loss worldwide. In our cohort, genetic screening successfully identified causative mutation in deafness genes, and 60% of congenital hearing loss patients shown in the left panel, and 36% of postlingual hearing loss patients shown in the right panel. In fact, GJB2 is the most frequent causative gene in the prelingual CI patients. Encoded protein connexin 26 is known to be localized in the cochlear and participate in potassium ion recycling in the inner ear. A series of reports indicated that deafness children with GJB2 mutations who received cochlear implantation showed good outcomes. As predicted, his language was well developed after bilateral CI. Auditory behavioral development assessed using the Little Ears Auditory Questionnaire showed excellent language development after CI. So this is next case. How about adult onset hearing loss? Genes also involved in these patients. This is the case of 47-year-old brother and his 45-year-old sister. Both of them noticed hearing loss in their 20s and started using hearing aids in their 30s. Answer is yes. CDH23 mutations were found, both of them. They have two mutations in the CDH23 gene. One is coming from father, the other one is coming from mother. So what is CDH23? What role does this gene play in the inner ear? This is again a genetic background of the CI patient in our hospital. CDH is known to be the prevalent gene responsible for late onset hearing loss. In our cohort, CDH is the most frequent causative gene of the postlingual CI or ES patient. This gene is known to be the responsible gene for Usher syndrome, USH1D, and non-syndromic hearing loss, DFNB12. CDH23 encoded cadherin 23. It is important protein to maintain a tip link of the stereocilia of hair cells. Will they have any associated symptoms other than hearing loss? Can genetic testing estimate these symptoms? Yes, the answer is yes. Genetic testing can estimate certain associated symptoms. Mutation types can be divided into two groups. In the case of missense mutation, found in this case, patients can produce protein with some residual function. Lead to non-syndromic hearing loss. However, nonsense mutation or frame shift mutation, which produce truncated protein, may cause Usher phenotypes. So genetic testing is very important for them to predict future phenotype. So what kind of therapy or intervention is the best for these patients? Of course, ES is the best solution for ski slope type hearing loss. You know that our university, Shinshu University, is located in Nagano Prefecture. We had 1998 Winter Olympic Games, and there are a lot of good ski slope around the city. And of course, we collected many patients with ski slope type hearing loss. What should you do when the candidate patient for ES visit your clinic? How can you predict the future audiograms? I'm asking because for ES candidates, hearing loss is more or less progressive. However, it is difficult to predict future audiograms. The speed of progression may be dependent on their etiology. Even with a 24 millimeter electrode, electric stimulation can cover all frequency. But a recent study indicated that longer electrodes offer a better speech perception compared with shorter ones. So if their hearing loss is predicted to be more progressive, a longer electrode is better. If their hearing is predicted to be rather stable, a medium length electrode will be applicable. Of course, in the case of cochlear hypoplasia, a medium length electrode will be better. This figure shows the natural course of hearing loss caused by CDH23 mutations. The average hearing for each group indicates that hearing loss is progressive. Together with the genetic information, I chose Flex 28 for this patient. Postoperative CT scan indicate that although the tip of the electrode reached the 125 Hz region, his residual hearing was well preserved, as you can see in this slide. So I hope you understand benefits of genetic testing. Genetic diagnosis ensure a more accurate diagnosis and suitable clinical interventions based on the predicted phenotype. Let me tell you about the discovery of deafness. There has been considerable progress regarding deafness genes over the last 2 decades. Currently, more than 120 genes have been reported for non-syndromic hearing loss. In this slide, blue indicates a responsible gene for recessive inherited hearing loss, and red indicates a responsible gene for dominant inherited hearing loss. So there are many genes, many kind of genes involved. So for screening, one by one gene screening is a time-consuming and costly method of screening. And therefore, simultaneous screening, such as next-generation sequencing, is needed. Let me tell you about current status of genetic testing for deafness in Japan. In Japan, genetic testing for deafness has been reimbursed by the social health insurance system since 2012 and has become a standard diagnostic tool for deafness. Currently, 63 deafness genes are being simultaneously analyzed. We have recently published that genetic background of 10,047 hearing loss patients. Based on our current results, GJB2 is the most prevalent causative gene, as in many countries, and major commonly found gene mutation for deafness in 30 to 40% of cases. The remaining cases of hearing loss are the result of various rare gene mutations that have been difficult to diagnose by a conventional one-by-one approach. So you can understand many genes are involved, but don't worry. The way of thinking is simple. This is a two most important aspect. First, is etiology intracochlear or not? The second, is hearing loss is progressive or not? These two things are very important. So this slide shows a basic theory concerning etiology and CI outcomes. This figure shows gene expression profiles of the causative genes and localization in the cochlea. When the genetic background is localized in the intracochlear, there is potential for good outcomes after CI. This figure shows the natural course of hearing loss caused by gene mutations found in the EAS patients. As you can see in this slide, the average hearing for each age group indicates that hearing loss is progressive. So now you are almost an expert on genetics. Let's discuss the decision tree, which is based on personalized cochlear implantation. So this is decision tree. It looks a little bit complicated, but for more detail, please visit my recent review article published in Anatomical Records. This review contains the cases introduced in my presentation. First, I recommend doing these three tests. These tests can divide a patient into several subclasses. I'm going to tell you what we can say from the result of identifying the responsible gene and recommended intervention. If GJB2 or OTOF is the causative gene, a good outcome can be expected. So bilateral simultaneous CI is recommended. This slide shows GJB2 associated hearing loss. GJB2 is expressed only in the cochlea. Therefore, good CI outcome is expected. In fact, as you can see in the slide, good CI outcome is obtained. Therefore, if we find the GJB2 mutation in the patient, simultaneous bilateral CI is recommended. This slide shows OTOF-associated hearing loss. The OTOF-associated hearing loss presents with an auditory neuropathy phenotype. That is, there is no response in ABR or SSR, but there is a response in ORE. However, OTOF expressed within the inner hair cell and play a crucial role for releasing neurotransmitter glutamate from inner hair cell. Therefore, etiology is located inside the cochlea. So good CI outcome is expected and actually achieve good speech perception in this case. Next, when SLC 26F4, POU 3F4, COL 4S6, are the causative genes. In a year, malformation with cochlear hypoplasia is expected. So selection of appropriate electrode is important. This slide shows SLC26A4 associated hearing loss. As you can see in the CD finding, enlarged vestibular aqueduct is associated with the patients caused by SLC26A4 mutations. In addition, incomplete partition type 2, IP2, is observed in majority of the patients. And in these patients, the size of second turn of the cochlear was smaller than normal. In these cases, appropriate length of electrode is needed. Audiological data. The patient with SLC at 26F4 mutations usually show high frequency involved hearing loss, and many patients have residual hearing in the lower frequencies. Therefore, ES is a good option for the patient with this gene mutation. But attention should also be paid at progressive nature. This is POU 3A4 associated hearing loss. CT findings show incomplete partition type 3, IP3 anomaly. In these cases, appropriate length electrode selection is important. And we also have to be careful about the perilymphatic gusher. And if CDH23 or LOXHD1 is the causative gene, residual hearing can be utilized, but progression is expected. So ES using longer electrode is the best solution. This slide shows CDH23 associated hearing loss. Overlapping audiogram showing high frequency hearing loss is characteristic feature of CDH23 associated hearing loss. Progression of hearing loss also needs to be taken into account. Therefore, ES with longer electrode is the best solution for these cases. Although there are individual difference in residual hearing after ES surgery, a patient caused by stereocilia-related gene mutation, such as CDH23, MYO7A, MYO15A, had a better preservation rate than cases of other etiology. Next, genes. If Usher syndrome is suspected due to mutations in MYO7A, PCDH15, or CDH23, early bilateral CI is recommended, as visual impairment is expected to progress. Hearing loss is congenital in Usher syndrome, but visual symptoms due to retinitis pigmentosa begins in teens. Genetic testing can predict late onset associated symptoms prior to onset. Therefore, early bilateral CI is recommended to keep quality of life even in the future risk of blindness. If OPA1 or DFNB 59 is the causative gene, the benefit of CI are limited because the cause is located outside the cochlea. Therefore, appropriate counseling and specific rehabilitation program will be needed. The OPA1, DFNB59, DIA, PH3 associated hearing loss. These genes are highly expressed in spiral ganglion and cause true auditory neuropathy. Limited CI outcome is expected. Therefore, careful counseling and rehabilitation with visual help will be necessary for them. So, this is a summary of my talk. It is important to know the region involved, inside or outside the cochlea, by identifying the responsible gene. Genetic testing is useful for predicting outcome of CI or EAS. From a genetic point of view, EAS using longer electrode is a good therapeutic option for high frequency involved hearing loss with progressive nature. Genetic testing is important for personalized cochlear implantation. Thank you for your attention. That's all.
Right, Professor Usami, I'm not sure that's all really, because I think there's a lot of knowledge there, and we've only had a short time to
I hope it's understandable.
I definitely think it is. So if you could stop your screen, there we go. So if everyone is thinking about questions, please, we have the godfather of genetics here. I have to call you that because really you are my hero on genetics for sure. So please put things in the chat. And while you're thinking about what you're going to do in the chat, we are going to do another Mentimeter. So if we can put that up, hopefully soon. And for those of you who don't have the code, when it comes up, have your handies, your mobile phones ready now. So there's the code 97338252, or scan on the QR code for a bit. And let's see. Right, do we think that everyone's ready? Here's the question. Is there reimbursement for standard genetic testing in your area? Okay, we are swinging around. Okay.
Yeah, good sign.
Yeah.
82%.
Not bad, isn't it? Oh, okay. Yes, it's winning now.
Okay, good.
Okay. It would be interesting to see what people define as standard genetic testing, you know, because maybe people have a different thing, like with your decision tree. So it will be good to see that. All right, so now what are we going to do? As is tradition, we are going to do our Experts Online group photo. So I would really like everyone to put their videos on so that we can wave and say hello. So while we put everyone's videos on, it's lovely to see people now, you know, because you just know that there's people up there, but it's really good to see faces, and that makes me really, really happy. Okay. How many more people are awake and alive? We still got more people coming on. So I'll shout when we do the photo. And all right. Oh, and more people. Yay, and more people. It makes me so exciting. I can't wait until we can actually go to meetings and conferences again soon. That's good. All right. So are we ready? Is everyone ready? Got your lipstick on? Fluffed your hair? Okay, let's all wave for the photo. And you keep waving until I say you can't wave anymore. So keep waving. And they haven't told me that the photo's done, so you're going to keep waving. And we're done. Thanks, everyone.
Okay.
Well, you know, it's good because it's a bit of exercise, right? Because you
exercise.
Yeah, well, you shouldn't be looking at your screen for so long with doing some other little bit of activity. Isn't that right? Good. So I'm not sure if we have anything in the chat right now, except okay, someone didn't have video. That's fine. That's all right. Dirk, that's really nice to hear that you're impressed and you explained some difficulties you had. Maybe it'd be interesting to hear what your difficulties were or whatever, and maybe other people could hear about them. Dirk? Or is that a no?
Yes, that's the problem. The last point was the auditory neuropathy. I had a patient, and I had very much difficulties with this patient to fit it. He got a sound bridge and a reimplantation of the sound bridge, and then a cochlear implant, and we had great problems to fit him because the progressive of the hearing loss later on, and hearing retirement, that was the great problem.
Yeah.
So that's the explanation for all these problems, I think.
Yeah, auditory neuropathy is difficult. Yeah. And but fortunately, only very limited portion of the patient had the real auditory neuropathy. So first, we recommend to do a CI together with some specific program for rehabilitation.
You know, Professor Usami, I thought it was quite interesting because you were also saying, well, maybe it's not really a CI there, but in the next slide you said it was like true auditory neuropathy. So how would you define the difference between true audio neuropathy and maybe not true audio neuropathy?
I showed the OTOF cases. They show positive OA response, but no ABR response. The phenotype is very much look like neuropathy, auditory neuropathy. But etiology is in the hair cell, not spiral ganglion. But phenotype, hearing testing, auditory testing, we diagnosed as a auditory neuropathy, but not real the etiology is not in the spiral ganglia, but
Okay.
in a hair cell. It's a pseudo.
Okay, pseudo. That's a good one.
Auditory neuropathy.
Yeah.
Genetic testing can divide it into real and pseudo.
Okay, so obviously then
But the phenotype, the testing, audiological testing, it looks same.
Yeah, so it's really down to the genetics again that really helps us with that. Now, you were talking in your different etiologies and genetics about some cases you would do a medium electrode and some you would do a longer electrode. So Pavel here says, do you observe any issues for your patients with using the longer electrode and residual hearing at the low frequencies? So do you counsel them beforehand, say, I'm going to try and preserve your hearing, or what's the risk, or how do you manage that? I guess, Pavel, that's what you're asking?
Yeah, we always telling the patient that there is some a risk to lose residual hearing, but in my experience, there is only very limited risk, and also we can tell that their hearing is progressive. So 10 years, 20 years from now, your hearing getting worse and worse. So longer electrode is recommended for you. We are telling, and together with genetic testing, the result of genetic testing.
So how would you manage counseling that, you know, do you even say that you may preserve that residual hearing? Are users very cautious about that because they do get something from their residual hearing? How do you manage that?
Yeah, most of the patient accepted my recommendation, but of course, some patient a little bit afraid of such a risk and wants to receive medium length electrode, case by case. But yeah. I always telling them the hearing loss is more or less progressive.
And I think that's really, sorry.
Yeah. Because it's very congenital ski slope type hearing loss. I never seen. It's always progressive.
Yeah, and I think it's really important. And like you say, it's a case-by-case basis, which is exactly why we're talking about individualized cochlear implantation, that we care about each person. And that's really
individual way of thinking.
Yeah, I think it is. We all are individuals with our own needs. So now we've got a question from Asha. Asa, I don't really know how to pronounce your name, but we'll go with it. So they're asking, what is your experience of EAS in SLC26A4, right, stroke IP2 malformations? In our clinic, they seem to have quite progressive hearing loss, and that's why they tend to take a long electrode. So what are your feelings on that one?
Most of them had has a hypoplasia of cochlear. So usually I chose a 24 millimeter electrode for the patient with SLC 26A4.
Okay, I hope that answers your question. So while other things are people thinking furiously about what they might put in the chat, when you talk to a family, say you've got a mum and a dad and you've already identified a genetic hearing loss in one of their children and you know which route to go, what else do you give them in terms of information, particularly if they want to have more children?
Mm-hmm. Yeah. I'm always providing together with genetic counseling.
Mm-hmm.
Sometimes with expert on that topic. But I'm personally have the license for expert genetic counseling expert. I have a license for that.
Okay.
Sorry. But sometimes together with other specialties, I'm always providing genetic counseling.
Yeah, you know, I think that is really, really important thing, because
Yeah,
if we're doing something, we need to really make sure the parents are informed about everything now with their child and maybe with future children.
Yeah, and the next generation.
Yeah, and the next generation. I know it doesn't stop at this line, huh? It keeps going down. Oh, I was going to have a grand question about that. Okay, so if you've got a child who's been identified, do you then recommend that the parents, A, test themselves, and B, do they test, or do you recommend them to test any other children they may have?
Yeah.
Yeah, okay.
I think so.
Yeah, okay, that's fine. All right. So I know in Japan you have everything reimbursed, but what would be your standard genetic test cost? How much would it cost?
400 euro.
400 euros. So it would be interesting to see what it would cost, say, in the rest of Asia or in Europe or in the US. What the variance of that?
I don't know. I don't know exactly, but in the US, 10,000. Oh, no. 10, yeah.
A lot more.
1,000 euro. 1,000 euro.
Yeah, okay.
400 euro in Japan.
Yeah.
Because we develop a cost effective method for screening.
Yeah.
And now we developed, and now the company is doing the screening.
Yeah.
So 400 euro is I think a very much cost effective way.
So how did you get this reimbursed? Is this because of a lot of evidence-based medicine to show that it really is?
I push government. I push government. I show the evidence and the benefits of genetic testing for deafness. And almost 10 years ago, government decided to be reimbursed.
Yeah. No, I think it's good, because even from 10 years ago until now, you've got a host of publications that people could use to lobby their reimbursement agencies if they aren't reimbursed already. So I think that's a good development in time. Right, so Victor has a question, and he says, are you doing NGS right away, or do you test for specific mutations in GJB2 before? Do you do CMA array in some cases? So how would you manage that?
No, NGS, next generation sequencing screening for every for 63 definite genes.
Okay, so
but of course, as you can see in my slide, GJB2 is extremely common. So GJB2 will be the first gene to be screened.
Okay, so But you would just do the NGS right away then? And you wouldn't do a CMA before? Because I've heard some people do that before they go into a more full-on NGS screening.
What?
So do you do a CMA array in cases? I think that was the other question from Victor.
She?
MA.
She MA.
Yeah. Okay, I think the answer's no then, because you are doing the NGS.
Victor,
maybe you want to, I can see that you're on video.
Yes, my question is in some cases where you don't have any result with NGS and you still don't have an etiology, okay. Or in some cases where you have you suspect a syndromic form of deafness,
that's right.
You can try another approach, for instance, chromosome microarray analysis or some other, to try to get an etiological diagnosis. That's the question.
Yeah. If we don't find any particular causative gene in the first screening, we then go to the next whole exome sequencing to find the responsible gene for them.
Okay, I hope that helps, Victor. Yeah, I'm taking that as a nod as yes.
Yeah. Because already 120 genes was identified. So we are doing screening for 63 genes. So we may miss some rare genes from our screening. So in that particular case, we do next step to analyze.
Okay.
Thank you very much.
All right, so Prof. Usami, I've had the pleasure of going through your genetic lab, and it was like outstandingly out of this world. But now, say I was a clinic and I wanted to set up my own genetics program. So what would you say is the minimum setup that a person should look for and get money from the heavens to set this up?
Minimum setup.
Yep.
Yeah. Probably GGB2. Yeah, it's a cheap screening. And what else? We have to keep in mind that etiology of the patient may be genetic. Yeah.
Okay, so that would be your basic, right? And if we had the next level up, you won the lottery and you wanted to spend that lottery money, what would be next?
But you know that the cost of analysis, genetic analysis, is getting cheaper and cheaper every year. So let's see the cost and benefits
over time. I think it's really an interesting question, really. Now, in your clinic, would you do genetic screening for every patient that comes in with a sensory hearing loss, or only when you're looking at a cochlear implant?
Yeah, all of the hearing loss patients, we recommend to do genetic testing. Because basically, the patient wants to know why I had hearing loss. It's a kind of fundamental question for them. Sorry.
Yeah, I think people want to know that etiology. When something's defined, you kind of feel better for it, I think, and accept it in that way. Now, when we talk about life, we always talk about diversity. Now, in your experience, do you think there are different ethnicities with different etiologies or different genetics?
Yeah, maybe some ethnic differences, but when compared with the article, and I think basically same gene,
Mm-hmm.
but different mutation, same gene, different mutation. In Japan, GJB2 is number one, but we had a different, mutation spectrum when compared with the population with European ancestry. Yeah.
Okay.
But
Well,
same gene.
yeah. No, that's really, really interesting. And I think that's a nice
Because
area.
we have a common ancestor. Our common ancestor is different from the Europeans, but
Yeah.
Adam and Eve. but basically, each population had different ancestor.
Yeah.
Sorry.
Yeah. No, I think that's really good and an interesting way to go forward. So I really, really want to thank you. I know that you're way past your bedtime, and I really appreciate that you have come and given, I think, us a lot of really, really valuable information. Certainly, I see that genetics is a key part in where we go along, and also, like you said, with, you know, giving each patient exactly what they need in an individualized manner, and I think that's really important. So I want to say thank you very much again, and it'll be good to see you in person soon.
Oh, now midnight.
Now midnight. Yeah, I think you can go to bed now.
Good night.
All right, so you have a good day, and now we can just look forward to the next Experts Online, and that's going to be on the 17th of November, same time, same place. And we're going to look at speech and language production of bilingual children. And we're going to particularly look at the highlights and clinical implications. And we'll be very pleased to have Christina Zarate and Ferenc Bunta to come and present on this. So once again, thanks everyone for joining us. I think it's been a good session, and I've certainly enjoyed it, and I hope you all have too. So I wish you a good night, a good evening, a good afternoon, or a good morning, and see you again soon. Thanks. Bye.